Good afternoon, everyone, and welcome to the 8th episode of the Medical Education Clinical Reasoning Program. We hope that you're finding this program to be useful and beneficial so far. As usual, let us start by introducing today's panelists. Our resident today is Dr. Abdullah Marzougi, and our two case discussants are Adia and Jumana. We will give our panelists the chance to briefly introduce themselves, and then we will start our episode. Dr. Abdullah, you can start, please.
Good afternoon, everyone. My name is Dr. Abdullah. I am an internal medicine resident in my second year of residency and at SKMC. And I'm happy to have the opportunity to do this with you. Hello.
Adia, can you please start by introducing yourself, and then Jumana?
Right, sure. Assalamu alaikum, everyone. My name is Alia Mazen. I'm a senior medical student. And it's my first time discussing the case, so I hope it goes well.
Good morning, everyone. Assalamu alaikum. I am Jumana. I am senior medical student as well. This is also my first time to be a discussant.
Okay.
Okay.
So let's start with the case. So we have a 20. So the patient name is A. Let's call him anything. Ahmed, for example. He's a 23 years old male. He presented because of trauma. Okay, so he's a 23 years old male. He works as an electrician. He was going to one of the houses to work in, and he was standing on a ladder to fix one of the wires, and then he suddenly got electrocuted and fell down from the ladder and fell on his back. So that's briefly the story. Alia and Jumana, one of you, please, if you would like to ask further questions, tell me what questions you would like me to answer regarding the history.
Okay, so when did that happen?
That happened like around 2 to 3 hours. So he was brought immediately after that by the ambulance.
Was he alert?
Okay, so he lost consciousness for like a brief, like few minutes, but then he was drowsy. He was able to wake up, but he's still tired and having pain from the fall. But he didn't lose like consciousness for a long time.
What about his burn? What percentage of his skin was burned?
There was no any other burns. There is no burns, no ulcerations, no skin changes. He only got electrocuted for brief minutes. So you need to ask what was he like holding the wires in his hand? Was he in touch with the wire? And you need to ask how many minutes he was electrocuted, and what happened exactly when he fell down. Like, did he fell down and woke immediately? Did he fell down and take long time to wake? Did he while he's waking, did he pass urine? Did he pass stools? Those things can tell you like an idea about what complications or what's going on with him. What other questions you would like to ask?
Did someone saw the incident?
Yes. So they did see the incident, and this is what they described. Okay, so let's move on. So this is briefly the past medical history. There is no really much to ask. There is only one more question you didn't touch on. So he fell from a ladder. So what you need to ask about that? And that's in regards to that.
Where did he fell on? What part of his body did he injure?
Yes, and that's important because you need to know, because falling on a a soft surface is not like falling on a concrete. So it's different.
Yes.
And
The height.
and the height, exactly. So he fell from like 8 feet ladder, and he fell on a hard surface, like the ceramic where they in the houses. He fell on that. And he fell on his back and he hit his head as well. So okay, now this is the case, and you came and you want to assist this patient. So you go into the room, you heard the brief story from the nurses or from the attenders, and then you went to see the patient. So let's start with, for example, Alia. Let's start with you. So what things you would do? Now this patient is in the room. You just entered the room. What things you would do?
So I will start with the primary survey. I'll ask for the vitals, and I will ask the patient if he can respond to and answer my questions. So I would check that his airway is patent.
Okay, so what do you call that approach?
ABC.
Primary ABCD, yeah.
Yes, exactly. Always go whenever you get asked what things you would do, the answer is always ABC. Okay, so you start with airway, breathing, circulation. So okay, let's start with one by one. So what things you check in the airways in the A?
If it's patent or not. So if he can answer,
Yes,
it would most probably be patent, as well as checking his voice, if it was hoarse or if it was normal. This would also give an indication.
exactly. Okay, and if you think that the airway and the part of the airway you always need to do with the airway is what? Is the GCS.
Yes, right.
Yeah, because the GCS can tell you an idea about the airways as well. So what is the GCS, Jumana?
Glasgow Coma Scale.
Okay, so how do you assess that? So what component? I'm not asking you to give me the whole scale. So what 3 components?
It's verbal.
Yes.
And eye opening and the motor response.
Exactly. Okay, so you assess this patient airway. The airways are patent. He can speak. He can talk. He can give you the history. He can tell you that he has pain. And also his GCS is around 14 out of 15 because he's a bit drowsy and confused and tired. But otherwise, the GCS is normal. So now, what is the next step?
Breathing.
Exactly, breathing. So what things you check in breathing?
We would check the auto saturation, as well as listening to the chest. So if it was bilateral air entry or any signs of pneumothorax.
Yeah, exactly. So you're going to listen to the chest, but before that, you're going to check the oxygen saturation.
Yes.
And the breathing pattern. Is he able to breathe? Is he apneic? He cannot breathe. How does his chest look like? So you need to look at that. Okay. And the third thing, Jumana, is?
The circulation.
So what things you do in the circulation?
We auscultate the heart, and we check the pulses, the peripheral pulses.
Yes, and so circulation. Think about the heart and the vessels. So what things you need to look at?
Blood pressure.
That's one of the most important things you need. Blood pressure, heart rate, peripheral pulses, and that's it. That's the most important thing. Okay, you don't really need to listen to the heart, because what is that going to tell you? Nothing. If you heard if you are really expert in listening to the heart, and you can really tell that you have this patient has a distant heart sound, or muffled S1 or muffled S2, then that's okay. But otherwise, it's an acute situation. You need to look at the vitals, blood pressure, heart rate, blood pressure on both arms, please. One more thing you can add on the C is insert 2 large bore cannulas.
Oh, okay.
Okay, so whenever you see a sick patient, put 2 large pore cannulas because you don't know. This patient might be stable now, but after 5 minutes he's crashing, and you need a line to insert, to give medications or give fluids or anything. So let's go back to the case. So this patient, ABC or okay. Okay, so vitals, he's vitally stable. Heart rate is 102. Blood pressure is 130 over 83. Respiratory rate is 18. Temperature is okay. He can speak. Breathing patterns are normal. He's warm to touch. So that's the ABC. They're all clear. So usually, like when we, like in medical school, they teach you, you start with history and physical exam, but in real life, you do all of them together. So this patient, because it's an acute state, you start with the physical exam, you get a brief history, then you go into the physical exam immediately. Then you go back to the history. So now you make sure that this patient is stable. He's not gonna die now. So what things you would like to ask about the history more? Like, let's move away from the past, from the history of present illness. Let's ask about other things in the history.
Okay, so does he have any medical problems?
Yeah, so you need to ask about the past medical, past surgical, medications, allergies, and other things. So all of them, they're normal. So he doesn't have any disease. He doesn't have any, he's not taking any medications. He doesn't have any surgeries. He doesn't have any family history of any kind of disease. He's not a smoker. He does not drink alcohol. So all of that is okay, is normal. So now let's go back to the exam. So you just cleared the most important things of the exam. Now you can take your time, get your stethoscope, wear your gloves, take your time and examine this patient. So tell me, what things you would like to examine in that patient?
So I want to expose the patient fully to check for any trauma or any signs of burns because he was electrocuted. I want to see everything.
Yes, that's important. So you expose this patient and you didn't see anything. There is no bruises, no signs of anything.
I'll do a fast exam.
Yeah, but yeah, the back, there was little bruising in the back, and there is like a mild swelling in the head.
Okay.
So
then
you
can start with the secondary survey. So we'll do from head to toe examination.
Yeah, you will examine everything. You'll examine the neck, the eyes. If you can speak, you can listen. You're gonna listen to the heart sounds. You're gonna listen to the breath sounds. You're gonna do an abdominal examination.
Yeah.
Okay, so all of those were normal. So he doesn't have any heart sounds, abnormal heart sounds. He doesn't have any crackles. His abdomen is soft. There is no signs of no neurological deficits. You need to look at the eye as well. So that the eye in this case is very important. If there's any pupillary dilation or anything, because he fell in his head. So you think of that. Okay, and those things are negative.
And the muscle movement, the lymph movements.
Why do you think of that?
Because he fell.
Okay.
So I need to check his movement.
Yeah, to see if he has any like a neurological deficit, because remember, trauma can give you bleeding in the brain, and bleeding in the brain can cause neurological deficit. So you need to think about that. So I am an internal medicine resident. I'm not a surgeon. So let's move on to the case, and we'll see what it is. So now this patient, you did your survey, you did your exam, you did your everything. So what next step you do? What investigations you would like to do?
So we do full workup. So CBC, electrolyte, kidney function test.
Yeah, you would do CBC, electrolytes, and you would do all of that, and then you need to do some imaging as well.
Yes. So I think part of the C, we could have done the EFAST to check for internal bleeding because it's a trauma case.
Yeah.
So we can do it now, يعني. Or we can do a CT trauma. So
Yeah,
we check
you would do full body CT because you need to know that this patient might have a skull fracture, maybe he has a hemorrhage, maybe you don't know. So you do a full body CT in any case of major trauma. But this is not really major trauma, but you would do a CT. So this patient had a CT done, and the CT was negative for any fracture. Okay, يعني he's okay, alhamdulillah. Now let's look at the labs. So okay. So let's look at the labs. So first of all, let's look at the electrolytes. The sodium is 143. Is it low or high?
normal.
Normal. Okay. Chloride is 103. Doesn't matter. Potassium is 6.6. Low or high?
High.
High.
High. Creatinine is 543.
High.
Urea, yeah, it is high. Urea is 27. CBC is hemoglobin is okay. White counts is 11.4, little bit elevated. Platelets are 537, little bit elevated.
Okay.
Okay. Coagulation profile is normal. Okay, so this is the labs you asked for, and this is what you saw. So what things you would do now?
I will do an ECG أصلا من قبل يعني بس now for because of the potassium it's very high.
Yeah.
I would like to see if there's any changes with the heart.
Okay, so you did an ECG. Can we get a look at the ECG as well? So this is the ECG.
Okay.
So I want someone to read the ECG for me.
Okay, so I can start.
Yes.
Okay, so checking the rhythm, it's regular.
Regular rhythm.
Regular rhythm. The rate is maybe 140, something like that.
It's around. It's around. Yeah. It's hard. It's a fast rhythm.
Yeah.
Yeah.
It's
Okay. What? Yeah, he is tachycardic.
There are some changes in the T waves, so I can see peak T waves in almost all the leads.
Yeah. Okay. So what do you call that? So what does that indicate?
Hyperkalemia.
So this is a peak T wave with hyperkalemic changes. Okay. So or in ECG with hyperkalemic changes. So then the next question is, what are the hyperkalemic changes you expect to see in a patient with hyperkalemia?
Depends on the severity of the hyperkalemia, I think.
Yeah. Okay. So let's look at them by one by one. So what do you get first? What do you get second? What things do you get? It doesn't matter. You correlate the ECG findings with the level of potassium, as long as you can identify the levels, as long as you can identify the ECG changes.
We can find the prolonged PR segments with the peak T waves.
So you get okay. So you first get a peak T wave. Then what do you get next?
Prolonged
what
PR.
changes? You get that later, but you get prolonged PR. What else?
We get a loss of the P wave.
You get a loss of the P wave and
prolonged QRS.
Wide QRS. Exactly. So you get a wide QRS. You get a peaked T wave. You get a prolonged PR segment, and then you get a diminished P wave, and then you can get a AV dissociation. So the P wave and the QRS are not complete hard block. They're not associated. And the final thing, what we call a sine wave. So it's like a zigzag. Okay, so
Yes.
it's a zigzag. So that's the final stage of hyperkalemia. And then the patient can go to asystole, the patient can go to a VTAC, and the patient can or will die if you don't treat it. So that's those are the changes you see in the ECG. So so that you did the ECG. We'll talk about the treatment later. So now you saw that the patient has a high creatinine, high potassium. The other electrolytes are okay. So now, so what other tests you would like to add to make a diagnosis? Now you have this. So what's the diagnosis? The first entity that you think this patient has? What do you call this?
Hyperkalemia.
Yeah, but the hyperkalemia is
Caused
because
by
of something.
electrical burn.
Okay, so the hyperkalemia is because of something. What is it? What's causing hyperkalemia?
rhabdomyolysis or يعني breakdown.
Okay.
But I can't
Yes,
remember.
yes. And how do you support that? So you have a theory. You think this is rhabdomyolysis. So what things you would order? What things that are there that supports your argument?
Maybe
Convince me. So okay, what do you get in rhabdomyolysis?
high creatinine.
Okay, so this creatinine, patient creatinine is high. What
Yes.
else you get?
Myoglobinuria.
You get a myoglobinuria. So did you do a urine analysis?
No, we should
Okay,
do.
so you need to do what? A urine analysis as well. صح?
Yes.
Okay.
Yes.
What other things you would see in blood? And the electrolytes. Let's talk about electrolytes. What electrolytes changes you see in rhabdomyolysis? Okay, so remember this. In rhabdomyolysis, everything is high except for calcium. So everything will be high, calcium will be low. So that's rhabdomyolysis. So calcium, you need to order calcium because calcium don't get it's a separate order. You need to ask for it. Okay, it's not usually in the electrolyte panel. So you would ask for calcium level. You will ask as well for which other electrolytes you don't usually get. You will ask for phosphorus and magnesium. Got it?
Yes.
Okay. So this patient, the calcium level was 1.7, which is low. Phosphorus 1.9, a bit high. And what else you would ask for for the blood? In the blood, you need to look for something that indicates muscle injury. So what things get elevated with muscle injury? Which specific protein or enzyme that gets high in the blood when you have a muscle injury?
Creatinine kinase.
Exactly, creatinine kinase. Okay, so what level, above which level you say this is a significant rise in a creatinine kinase? Because you might go to the gym and you get a high creatinine kinase. So what level that will indicate that this patient might have rhabdomyolysis? Okay, so it's above 5,000.
Okay.
So above 5,000, you don't really have to know this, but this is for your information. It's above 5,000. Okay, it's rhabdomyolysis. So the creatinine kinase in this patient was 60,000. Okay, so let's look at the urine analysis. So now let's see what urine analysis. Okay, so tell me what things you need to look. You have the urine analysis sheet with you. Now tell me what things you would look for in the urine analysis. Okay. يعني what are you going to really focus on? Are you going to really focus on specific gravity? Are you going to focus on the what things in the urine analysis you need to focus on that can direct your reasoning and your diagnosis?
The gravity.
No, okay. So what's specific gravity? Specific gravity tells you that this urine is concentrated or not. It's not really specific. You can get a high specific gravity in million diseases. So that's not really specific. So you need to look things that supports. Okay, Khas, let me go a step back and then we can talk about it. So this patient has high creatinine. Okay, so acute high creatinine, we call that acute kidney injury. Okay. So this patient has acute kidney injury. Now, acute kidney injury, you define it by increased creatinine. Now, you have a high creatinine. Now, you need to see what things that can differentiate which type of acute kidney injury is this. So how do we classify acute kidney injury?
Post-renal, pre-renal,
And
intrarenal.
intrarenal. Okay, so now how do you differentiate between post-renal, intrarenal, and pre-renal? Based on the urine analysis, based on the history. So tell me, now this patient, the history, what does the history indicate? Which etiology the history mostly indicates?
Pre-renal.
Okay,
Yeah.
so it's definitely not post-renal.
Yes.
Because this patient does not have BPH, he's young, he does not have any stone, he fell, so it's definitely not a post-renal. Okay, so it's either intrarenal or pre-renal. So والله أنا صراحة I don't know. How do I know? You do a urine analysis. Urine analysis can guide you. So okay, you did a urine analysis. What things you would see in the urine analysis that can tell you that's most probably pre-renal or this is most probably intrarenal?
Maybe the presence of erythrocytes.
Okay, so erythrocytes. If you saw or if you see RBCs in the urine, it's really unspecific. But if you see RBC cast, what does that indicate?
Intrarenal.
Which part of the intrarenal? Where is the lesion? Where is the disease? If you see an RBC cast.
Tubular.
No. Think of something bloody, something with foot, something in the nephron, which is full of blood. The glomerulus.
Glomerulus.
Yes. So okay. So intrarenal. Let's further break down intrarenal to 4 things: tubule, glomerulus, interstitium, and vascular. So that's the 4 components of the nephrons. You have tubules, you have interstitium, you have vessels, and you have a glomerulus. So if you saw an RBC cast in the urine, so that tells you that it's most probably glomerulus. Okay, so then you would think of other things. You would think of SLE, you would think of Wagner, you would think of Church-Strauss, you would think of any multiple things you would think of. Okay, in the glomerular entity. Okay, so this patient does not have any RBC cast. Okay, so what other things you would look for? Can direct your reasoning in any case of acute kidney injury in the urine analysis. So what about nitrates and leukocyte esterase? What are those?
These are indicators of bacterial infection.
Yeah, so if you have a high nitrate or high leukocyte esterase, what does that tell you? That the patient has an infection, has a UTI. Okay, so if I have a patient with high creatinine and has a high nitrates and high leukocyte esterase, then that's most probably is a UTI. So that you have your diagnosis. So this is a one cause of intrarenal cause of acute kidney injury. Okay, a UTI or an infection affecting the interstitium. Okay, so okay. Now, in cases of, there is one more specific test that can really tell you, that can really help you, and you see it a lot in exams. Have you heard of functional excretion of sodium?
No.
Okay, so basically, when you have a pre-renal injury, so what's the pathophysiology? So you have a pre-renal injury. What does the kidney tries to do? What does the body tries to do to compensate? So basically, what is pre-renal? It's decreased renal perfusion to the kidney, okay? Now you have a patient with decreased blood or volume to the kidney. Now what does the body tries to do? Tries to increase the volume.
Yes.
How does it do that? Which hormonal system gets activated?
renin-angiotensin.
Exactly, renal angiotensin aldosterone system. What does that system? How does that system affect the sodium absorption? Does it increase it? It's yes. So it increases it. Increases sodium absorption from the proximal tubule. Okay. So if you have a patient and you measure the urine and you saw that the urine sodium is low, so that means what? That means that the renal angiotensin aldosterone system is working.
Yes.
صح? Because it's reabsorbing sodium, and the other things that it can tell you that the proximal tubule is intact. It's not damaged, because if it's damaged, it won't absorb sodium.
Right.
So if you have a high renal aldosterone angiotensin system and intact proximal tubule, that tells you that it's pre-renal cause. So it's decreased blood volume or decreased volume to the kidney. The kidney itself is intact. There is nothing wrong with the kidney. What's wrong is the things that are before the kidney, the heart, the vessels, whatever. Okay?
Okay.
So low functional excretion of the sodium is indicative of pre-renal injury.
Okay.
Okay, if you have a high functional excretion of sodium, what does that tell you?
Kidney is not working.
Okay, which part of the kidney is not working?
The proximal tubule.
Exactly. So what do we call that entity where you have a damage in the proximal tubule or on the tubules? There's a famous name.
Tubular acidosis, acute tubular
No.
acidosis.
No. Okay. Acute tubular is right. The last thing. It starts with the N. Acute tubular necrosis. ATN.
Yeah.
ATN. So in ATN cases, you get damage to the tubules and the sodium gets high in the urine. So if you saw a patient with high urine sodium, that tells you the patient most likely have ATN, acute tubular necrosis.
Okay.
I feel like I confused you a lot. Do you have any questions, or do you feel like it's getting complicated?
No, doctor, it's okay, but it's been a long time since we revised the physiology.
Yeah, it's for your purposes, because not all of you is going to go to internal medicine, so you need to connect physiology and pathology. That's your level. Then when you go to residency, we will talk more about management. So that's basically things that can help you. Now in this patient, you think the patient has rhabdomyolysis. So what specific thing you would look for in the urine? Specific thing. How does rhabdomyolysis cause renal injury? So which protein gets out of the muscles? Which protein they get accumulated in the kidney and causes renal injury? What do you call that globulin? What does it?
Myoglobulin.
Globulin.
So when you have when you have increased myoglobulin in the blood, that myoglobulin can go to the kidney and causes acute kidney injury. Okay, so this patient is in front of you. You diagnose the patient. So this patient urine has positive myoglobulin, or myoglobulin is high. So you have this patient, myoglobin in the urine, high creatinine kinase, low calcium, all electrolytes, other electrolytes are normal or increased, and he has a recent injury to the muscles. So that seals your diagnosis. You made sure that this patient has rhabdomyolysis. Now this patient is in front of you. You have access to all medications in the world. Tell me, what are you going to do to this patient? Which medications are you going to give?
I'll start with saline.
Okay. So let's see the issues of this patient. So the first issue is rhabdomyolysis. Okay. Agree?
Yes.
Okay. The second issue, which is more urgent, is what? Look at the ECG.
The hyperkalemia.
Yeah, that's urgent. That's gonna kill the patient now. Rhabdomyolysis is gonna kill him tomorrow. So this is gonna kill the patient now. So we need to act upon this. So how do you act? You have a patient, potassium is high. What are you going to do?
Okay, so we start with the calcium gluconate to protect the heart.
Okay. So when do you give calcium gluconate? Do you give them any on all patients with hyperkalemia? So a patient presents with hyperkalemia of 5.5. Another patient presents with hyperkalemia of 6. The other patient presents with hyperkalemia of 7. The other patient presents with hyperkalemia of 10. So which one you give calcium gluconate? Do you give all of them?
No, maybe just the higher ranges.
Okay, define higher ranges.
More
Okay,
than
so you give
6.5.
Okay, so let's think logically. You give calcium gluconate, you said, because you want to protect what?
The
The
heart.
heart. صح? Okay, so if you saw a patient, no matter what is the calcium level or potassium level, you saw a patient with hyperkalemic changes at the ECG, you're gonna give them calcium gluconate because this patient has a cardiac injury to the heart because
Okay.
of hyperkalemia. So you're gonna give them calcium gluconate. So that's the first indication. If you have any patient with ECG changes, you give them calcium gluconate and that's it. Okay?
Okay.
Okay.
Now the second thing, just a protective factor in higher ranges. So it's usually you give them in 6.5. Above 6.5, you give calcium gluconate. But that's not really like I mean, not everybody has agreed upon this. I personally, in my patients, I give it to any patient with potassium 6.5 or above. And other doctors, they say if there is ECG changes, I will give calcium gluconate. But let's take the most important thing: ECG changes, give calcium gluconate. Now that's the first thing. Okay, you give this patient calcium gluconate. What else are you gonna go? What else are you gonna give?
Hypertonic normal saline.
Okay, why do you give hypertonic normal saline? There is a lot of noise. Okay, so what's hypertonic normal saline? Jumana, you answered hypertonic ولا عليا?
Jumana.
Okay, Jumana, what's hypertonic normal saline? Okay, so normal saline is a water basically with salts in.
Yes.
Sodium chloride. So hypertonic has more salt to water percentage. So
Yes.
it's really about sodium. It has nothing to do with potassium. So hypertonic normal saline will not affect the potassium levels, will increase the sodium levels. Okay. So now we're talking about potassium. If this patient has a low sodium, then that's your answer. But in this patient, he has the potassium levels are high, so you don't give hypertonic saline. You don't give saline. You don't think about saline now. So you think things that can affect the potassium. So let's think about the potassium in general. So you want to get rid of the potassium. So you get rid of it. Either you release it in the gut, or you release it in the urine, or you're gonna shift the potassium inside the cells. That's the three ways. Or you release it from the breath. So only those three cells, those I'm sorry, forget the last one. So only those three things you're gonna do in hyperkalemia. You either shift the potassium inside the cells, you either release them in the urine, or you release them in the stools. So only
Right.
those three ways to release high potassium from the urine, from the blood. I'm sorry. So you have hyperkalemia. So tell me what drugs, which management things you're gonna give to affect each one of them. So okay, I want to shift the potassium inside the cell.
Insulin.
Yes, exactly. You give insulin. Now you're gonna give insulin
Dextrose.
with dextrose, because you don't want to kill the patient from hypoglycemia. You're gonna give insulin and dextrose. That's the first thing to shift the potassium inside the cells. What other things you're gonna give to shift the potassium inside the cells?
Beta blocker.
No,
Beta
beta 2
blockers, no.
beta
Beta
2
agonists.
Yeah.
Exactly. You're gonna give salbutamol nebulizers.
Yeah.
That's it. Okay, you shifted the potassium inside the cells. What other things you need to do? You're gonna release
Now,
the potassium from the urine.
right.
Yes.
So we will
What
give
what
furosemide.
you're gonna
Furosemide.
get Lasix. You're gonna give Lasix or
Yeah.
furosemide. Okay. And the last thing, you're gonna stop the potassium from getting released through the gut, which is through calcium resonium. Memorize that. Okay, calcium
Yeah.
resonium. Now, in this patient, so that's generally hyperkalemic treatment. In this patient, like his creatinine is 500, you're not gonna give him Lasix, because
Yeah.
Lasix will increase the creatinine. So you're gonna keep that later. If he didn't respond, then maybe yes. What you're gonna give him is dextrose and insulin. Always in hyperkalemia, high hyperkalemia, you're gonna give insulin and dextrose. Remember that, you'll never be wrong. Insulin and dextrose. This is the fastest and the most effective way of treating hyperkalemia. Insulin and dextrose. So this patient received calcium gluconate, received insulin and dextrose. You repeated the potassium, the potassium levels dropped to 6. It's okay. It's gonna take time. We are good. We're safe. Now that's hyperkalemia. So what about rhabdomyolysis? How do you treat rhabdomyolysis?
So I think we should focus on fluids
Exactly. Why?
because we need to excrete the excess myoglobin and the excess يعني creatinine.
Exactly. Because the patient has increased in myoglobin and creatine kinase, and that
Right.
increase in creatine kinase are getting inside the tubules, and they're causing toxic injuries to the tubules. So you're gonna wash that fluids. You're gonna wash that blockage by fluids. So you're gonna give fluids. So always in acute kidney injury, treatment is fluids, always. Okay. In pre-renal acute kidney injury, the answer is fluids, except in few cases. We'll talk about them later. So you're gonna give fluids, and then that will release that will clear the creatine kinase, and then the patient will improve. Okay.
Okay.
Okay. So just let me ask you, if any patient presents with acute kidney injury, when are you going to go for dialysis?
I think if it was يعني in regards to hyperkalemia, if it was very high, I wouldn't wait for the drugs or the insulin. I would take them for hemodialysis.
No, insulin works very fast. Okay. So
Okay.
so remember, hemodialysis is not something easy. You need to go to the patient. You're gonna insert a line, and then you're gonna break the machine, and you're gonna dialyze, and that's even scary to the patient and the nephrologist as well. So you don't go to dialysis except after you finish all your treatment. You finished everything you can, and you couldn't drop the potassium. Then you do dialysis. So the
Okay.
first indication is hyperkalemia, not
Okay.
responding to dialysis. What's the second indication? There are 5. So the second indication is think about kidney injury. What kidney does? So what about acid base? If you have acidosis,
That's right.
okay. So if you have acidosis, that is not responding to the treatment, I'm not going to go to the treatment of acidosis because it's advanced for you. So if you have acidosis not responding to treatment, you go for dialysis. Okay, that's the second indication. The third indication.
If there was يعني mental state changes, so if the
Okay,
patient was
exactly,
lethargic,
exactly,
unconscious.
exactly. So that relates to what? So what causes abnormal mental status in patients with acute kidney injury?
uremia.
صح, exactly, uremia. So if you have uremic symptoms, what uremic symptoms means? واحد, altered mental status or uremic encephalopathy. So you have a patient with altered mental status, confusion, unconscious, coma. So that patient, خلاص, you need to dialyze. The second thing, if you have a pericardial effusion. So if you go to auscultate the patient, oh, he has a rub, then that's indication for dialysis. Okay? The fourth thing is if the patient has an acute kidney injury due to heart failure. So what things in heart failure that can...
Fluid
So
over.
exactly, if you have a patient with fluid overload. So that's the only exception for fluids rule. If you have a patient with acute kidney injury and he has a massive edema, he has a heart failure. So in that case, you give what? You give Lasix, you give diuretics. Why you give diuretics? Diuretics can hurt the kidney, but what are they going to do in patients with heart failure and volume overload?
Decrease the fluid, so it will lessen the strain on the heart.
Yes, exactly. صراحة يعني أنا حي هذا يا جوبا. Increase, it will lessen the strain on the heart. It will make the heart pumps more, so it will improve the kidney. But if you give Lasix, the patient cannot respond. You don't really, you cannot really give a lot of Lasix. Then you go for dialysis for volume overload. The last thing is the dialyzable toxins. If a patient ingested 100 tablets of acetaminophen or not acetaminophen, NSAIDs, or ingested a lot of aspirin, or ingested a lot of toxins that you need to dialyze, then you do dialysis. Okay, it's a way to clear toxins. So that's the 5 indications for acute kidney injury that's requiring dialysis. But remember, the rule is you always try with drugs, then you go for dialysis. You don't go to dialysis immediately. Now, let's go back to the rhabdomyolysis. You give fluids, and in this patient, really, we gave fluids, and the patient improved. And then he was discharged in the next 2 days. I have like 9 minutes. Let me ask you about like acute kidney in general. So what are the causes of pre-renal acute kidney injury in general? So what entities that will give you pre-renal acute kidney injury?
Atherosclerosis.
Arteriosclerosis of the kidney, of the renal artery. Yeah, that can give you acute pre-renal. So arteriosclerosis. What else in the renal artery will give you pre-renal? Something very commonly tested.
Occlusion.
Yeah. Okay. So a patient, he has hypertension. You give the patient ACE inhibitor. He comes back and creatinine is jumping.
So that's renal artery stenosis.
Yes. Renal artery stenosis. So that's the first cause of pre-renal injury. What else?
Hypovolemia in cases of dehydration.
Sepsis.
Hypovolemia, dehydration. Yeah, that's okay. And the last thing, volume overload. Okay.
Yeah.
Heart failure, liver failure. The mechanism is a bit complex, but basically the fluids is not inside the vessels. It's shifting outside the vessels. The volume inside the vessels is low. That's why you get acute kidney injury. So that's pre-renal. So intrarenal, basically, just what causes intrarenal? So we said tubules, we said glomeruli, we said interstitium, and we said vascular. So what causes in the tubule? What causes ATN? The most important causes in ATN. Drugs, absolutely. What else?
Hypotension.
Pigments. Okay.
يعني
Pigments. If you
toxins.
hypotension causes pre-renal. Pigments. If the patient has a like pigment disease, for example, a patient had rhabdomyolysis, a patient had increase in uric acid, tumor lysis syndrome, for example, those things, contrast. You give patient contrast, develop. So those things can give you what? ATN, acute tubular necrosis. Okay. We told you about the glomeruli. Let's talk about acute interstitial nephritis or acute interstitial disease. So what things in the interstitium? What are the things that can cause interstitial? Infection, that's the first one. What's next?
يعني what is it called? Like SLE?
Yeah, autoimmune diseases. Autoimmune diseases can cause interstitium. Scleroderma as well. So just a couple of things that can really come a lot in the exams. Couple of things. Use similes, okay? Two things. A patient had taken a drug, and then he developed high creatinine, reduced urine output. When you measure the urine, you saw eosinophilia. There are eosinophils inside the urine. What is the name of the condition? What's the cause of AKI?
Is it Strauss?
No. In the urine, it's not in the blood. So in the urine, you have eosinophils in the urine. They come a lot in the exams. This is allergic interstitial nephritis. So it's an allergic reaction. Okay.
Okay.
The last thing, a patient with scleroderma comes with high creatinine. So what's that? Comes a lot in the exams. That's a scleroderma renal crisis. Why I focus on this? Because the treatment is really specific. You need to know the treatment. So this is the only condition, and the only condition where the patient has an acute kidney injury and you give them ACE inhibitors.
Oh, okay.
Exceptions, they come in the exams a lot. So this is an exception. Patient, acute kidney injury, scleroderma, give ACE inhibitors. Okay. The last thing is vascular. So the patient has vasculitis. So which type of vasculitis that can cause acute kidney injury? Which vasculitis? Yani usually causes renal injury.
Small vessel vasculitis.
Yeah.
Small vessel vasculitis. Yeah, small vessels it can cause مثل Wagner's and other things. But there is something else. Something that affects the vessels itself. Wagner's, they cause. Okay, you're right, but there is another disease in the medium vessels vasculitis that usually presents with renal issues.
ANCA vasculitis?
PAN, polyarthritis nodosa.
Oh, okay.
Polyarthritis nodosa, neurology, nervous system, skin, and renal. Those three systems get involved, and aneurysms in the gut. So that's basically like overview. And also one more cause of the vascular, malignant hypertension. Patient hypertensive crisis, he comes with urine, with acute kidney injury. So that's hypertension crisis causes intrarenal disease. So basically, like the acute kidney injury is really very, very general, very big topic. You cannot really cover everything. But I hope you got some benefit from the case and from the approach to treatment. So do you have any questions?
No.
I think all was clear, Doc. Thank you very much.
I didn't see the comments. Any one from the from the volunteers have any question? Hello.
Okay, thank you, Dr. Abdullah. Thank you, Alia and Jumana, for this informative and insightful discussion. It seems that the audience did not share any questions in the chat box, so they can always share their questions on our website or on our social media. We'd
Yeah.
like to conclude today's session. It was very enlightening. I would also like to thank the audience for attending, and we hope we meet you all again next week.
Yeah.
Thank you.
I just have a one comment.
Yes, of course, Doctor.
Yeah. Just for people, for internal medicine in general, like it's one of the specialties where real life really differs from questions in the exam. So usually when you study anything or any entity or any disease, don't really memorize the symptoms, because every disease can give you most of the symptoms. So always things that are very specific, things that will really come in that disease itself. So myoglobin in the urine, it's only rhabdomyolysis. So always think of things that are really specific to the to the to the disease itself, and that's usually what comes at the exam. Okay. Bas.
Thank you for this comment, Dr. Abdullah, and we're actually really glad to have you with us because you always shed light on these specific conditions. We hope we meet you again in another case discussion, inshallah.
Okay. Thank you.
Thank you.
Thank you.
Thank you very much.